Going to be talking just about the pro-resolving lipid mediators of inflammation. And this is a relative new area and a relatively new class of lipids. I'm not going to dwell on this. We've already heard about omega-3 fatty acids, and certainly over the last 2 to 3 decades there's been a lot of interest in omega-3 fatty acids in relation in particular to cardiovascular disease. And they've been shown to have some benefits on a number of the risk factors shown here, including inflammation. But in fact, I'm not going to talk about inflammation and the anti-inflammatory effects of omega-3 fatty acids. I'm going to talk about their pro-resolving effects. And this hopefully will become a bit clearer as we go into the presentation. But just to clarify, when I'm talking about omega-3 fatty acids, I'm really talking about just EPA, or eicosapentaenoic acid, and docosahexaenoic acid, the 20 and 22 carbon fatty acids, to which most of the benefits have been ascribed. We've heard about inflammation from Andrew and a number of the speakers during the course of the day. And really, I don't really need to elaborate too much to this audience about inflammation, other than to really put it simply that it's part of a host's normal protective and defense mechanism, I guess, against tissue injury and infection. But really, we know that if it's uncontrolled, it can lead to acute, chronic and systemic inflammatory disorders, for example, cardiovascular disease, diabetes, and so forth. I guess up until not that long ago, we thought that the resolution, if you like, and I hate to use that word since that's already in the title, but the resolution of inflammation was something that really occurred passively. In other words, the pro-inflammatory mediators dissipated and homeostasis was returned. We now know that's not the case, and in fact the resolution of inflammation is an active process, and there are a number of metabolites involved in this process, and they're called the specialised pro-resolving lipid mediators, or I'm going to refer to them as SPM, it's a mouthful. They're derived not exclusively but predominantly from N3 fatty acids, and we know, and you'll see in a moment, that they actually operate through receptors and they're actively trafficked to the site of inflammation. So, excuse me, in cartoon form, during the initial inflammatory insult, you get edema, and this associates with the release of pro-inflammatory prostaglandins and leukotrienes, typically PGE2 and leukotriene B4, and also associates with the classic symptoms of inflammation, heat, redness, swelling, and so forth. But as I said before, unresolved, this can lead to chronic inflammation. What we now know, however, is over a period of hours and I guess days, these same cells that can actually generate the pro-inflammatory lipid mediators can actually undergo what's called a lipid mediator class switching. It's not really understood how this happens, or the molecules that are or the mediators that are responsible for this, but it's thought to be partly due to PGE2 and PGD2. What this does is it actually switches these monocytes, macrophages, and PMNs to generate these lipid mediators that actively resolve the inflammation and return the system to homeostasis. So what are these SPMs? Well, we've known for a long time about the lipoxins derived from arachidonic acid. But what we now know is that the omega-3 fatty acids, EPA and DHA, are actually the main drivers of this at this stage. And those metabolites derived from EPA and DHA are orders of magnitude more biologically active than the lipoxins. Now, I could have put up a complicated slide like Peter, but I chose not to. So this is a very simplified cartoon. Essentially, from EPA through either a COX-2 aspirin or a CYP450 enzyme system, you get the generation of this 18-HEPE and a series of metabolites collectively called the E-series resolvins. From DHA, it's a little bit more complicated. Through either a COX-2 aspirin pathway or a 15-lipoxygenase, you get a number of metabolites collectively called the D-series resolvins. And I said it was more complicated from DHA. I won't go into the mechanisms, but essentially a second class of metabolites from DHA, collectively called the protectins, and through a macrophage 12-lipoxygenase pathway, another family of compounds called the moresins. So you can see collectively there are quite a few of these SPMs that can be derived from EPA and DHA. And it's a case of watch this space. The number of members in these families is growing essentially yearly. So what do? Well, first of all, we know that they're synthesized in epithelial or endothelial cells in airways, retinal pigment epithelial cells, monocytes and macrophages. Their actions are many. They essentially blunt PMN infiltration. They provide a stop signal to limit further PMN recruitment and PMN-mediated tissue damage. They enhance macrophage phagocytosis of apoptotic neutrophils, cellular debris and bacterial killing. And they provide broad anti-inflammatory and pro-resolving actions at both a translation and transcription level. Importantly, what they do is they counter-regulate or they attenuate a number of the pro-inflammatory mediators, such as the leukotrienes and prostaglandins. They also attenuate the formation of platelet activating factor, chemokines and cytokines, reactive oxygen species, and edema. But they also activate anti-inflammatory mediators, such as nitric oxide, prostacyclin, heme oxygenase, etc., including upregulating adiponectin. And as I mentioned at the outset, a number of receptors have been, the G-couple protein receptors have been identified for several of the resolvins, and I guess this family is going to grow as more are discovered. Most of the research to date has really been carried out in vitro. In fact, that's where it started, in vitro, and in small animal models, typically rodents, that are subjected to an acute inflammatory insult. So I've put in pale yellow in brackets those SPMs, those resolvins that have been associated with a number of conditions of predominantly acute inflammation. I won't go through those in detail. The studies in humans are very, very limited for obvious reasons, much more difficult. What we do know, however, is these SPMs are substantially diminished in patients with these particular conditions. They have been shown to be present in Alzheimer's disease, brain, breath condensates, and also adipose tissues of healthy individuals. And like Peter, we also use the same technology, which is liquid chromatography tandem mass spectrometry. In our case, however, we only really target those metabolites that we have that we have standards for, and we use very specific techniques in which to home in and identify these metabolites. But essentially, it's the same sort of technology. So I showed you this slide a little bit earlier, and I said to you these SPMs can be derived through a number of different sort of enzymatic pathways. And I mentioned they can be derived through one of the pathways for both the EPA and the DHA metabolites is through a COX-2 aspirin activation. So some of the early work actually suggested that if you put aspirin into the system, you can generate these resolvins. So our thought at the time was, well, what happens if you give someone or people N3 fatty acids? After all, they're the precursors. And then you give them aspirin on top of that. Can you actually amplify the response in terms of production of these resolvins? And that's what we did in a series of experiments. This was the first of our papers. And in fact, to give you an idea how relatively new this field is, this paper here was actually the first to report in human plasma a series of resolvins. Other people had identified several of the resolvins, and we were the first essentially to describe a whole series of them. So what did we do? We took, in this very simple experiment or study, 21 healthy volunteers, and we put them for 7 days on relatively, well, I was going to say low dose, moderate dose of N3 fatty acids, 2.4 grams per day. And during the last 2 days, they were randomised to either aspirin or placebo, and blood was taken at each of those 3 points. In other words, could we amplify the response with aspirin? Well, I won't go through all of the metabolites that we measured, just to give you representative of those derived from EPA. And again, we showed quite clearly significant increase in the E-series resolvins from EPA after N3 fatty acids, as also those derived from DHA. So clearly we're able to increase their synthesis. However, when we, and this is just a different way of showing the data, however, when we added aspirin over the last 2 days, there was essentially no further increase in the production of these particular metabolites. So aspirin seemed to have no additional effect. I guess that got us thinking, is it because the supplementation wasn't long enough? Did we have the wrong patients? These were the wrong individuals. These were healthy individuals. So we repeated this study, but we repeated it in groups or individuals that had features of the metabolic syndrome. And so we had 43 volunteers in this study, 22 with features of the metabolic syndrome and 21 controls. And those with metabolic syndrome-like features, not surprisingly, were overweight, had higher blood pressure, fasting glucose and triglycerides, as I guess you might expect. So both we'll call them metabolic syndrome and controls, were placed this time on a similar dose of N3 fatty acids for 4 weeks, and during the last week given a daily dose of aspirin with blood taken, again, baseline 3 and 4 weeks. We did measure plasma phospholipid fatty acids and showed good compliance. So I won't show that data. Again, I'm just showing 3 typical SPMs that we measured. We measured a number of both EPA and DHA SPMs. What we did show was during the course of N3 supplementation, there was a significant increase in the SPMs derived from EPA or DHA. However, you can see clearly that in those individuals with features of metabolic syndrome shown by the dashed line, the response was significantly attenuated. It was greater than 50%. So really the response in individuals with the metabolic syndrome, despite the fact that they showed a similar increase in N3 fatty acids with supplementation, was attenuated. And the second point to note is that, again, aspirin really had no additive effect. So overall, with these studies, we showed that N3 fatty acids can increase SPMs. The responses are attenuated in individuals with metabolic syndrome-like features. And really, aspirin doesn't seem to add any additional benefit. And it may be that you're overwhelming, if you like, if that's the right term, the system with N3 fatty acids. We've performed a number of other studies in other at-risk, if you like, populations. This was one that was published earlier this year in patients with chronic kidney disease. We've already heard that these patients, I think it was Andrew, are at increased risk of cardiovascular disease, and of course inflammation is a major driver of this. So for this study, we recruited 85 males and females. They were class 3-4 chronic kidney disease. We randomised them to N3 fatty acids or placebo for 8 weeks and took blood at baseline and at the end of the 8 weeks. And again, I'm just showing you a select number of the SPMs that we measured, but quite clearly they were significantly increased following N3 supplementation. Now, you can see that these SPMs are measurable also in the individuals that weren't supplemented, and that's simply because everybody has some N3 fatty acids in all their tissues. And this is just another one that we measured. So in this study, I guess we showed that N3 fatty acids may be useful in limiting low-grade inflammation in these CKD individuals, and I guess that's something that needs to be followed up. And We've also, I think it was Andrew again, that talked about arthritis and that inflammation is essentially a major driver in this particular condition. This was a study that we published earlier this year in collaboration with Les Cleland from the Royal Adelaide Hospital, a rheumatologist there. And he routinely puts his patients on high doses of fish oils. And when I say high doses, anything between 10 and 25 grams per day of fish oil, which seems to be the dose of N3 fatty acids that's required, to really be effective in this condition. So for this study, we recruited 36 patients, and these were patients that were going arthrocentesis. And so we were able to actually obtain synovial fluid simultaneously with peripheral blood from these patients, and 36 controls. And the controls, I won't go into it, but the controls from the general population. But the controls were also supplemented with N3 fatty acids so that the dose of N3 fatty acids between the patients and controls was actually comparable. And what we showed here was that, again, with N3 fatty acids, there's a significant increase in the level of these SPM. But surprisingly, if you look on the left-hand side of each of the panel, the plasma levels in those patients with arthritis were significantly higher than those in the controls. And the plasma levels in arthritic patients were significantly higher than in synovial fluid. And this was the same for the EPA and the DHA SPMs in all of them, and I won't go through them in detail. But what was of particular interest was that when we looked at a number of associations, we found that SPMs in synovial fluid and plasma inversely associated with ESR, which in these particular patients is a marker of inflammation. This particular resolvent E2 in synovial fluid inversely associated with patient pain score. And all of the E series and D series resolvents associated with the duration of treatment. There was, however, no association with the dose of N3 fatty acids or the only marker of inflammation that we had, which was CRP. And I'm not going to go through that. I've already said that. Other than to say that these data, I guess, suggest that N3 fatty acids may well provide an avenue for the synthesis of SPMs that may well be important modifiers for inflammation in these patients. And in the last minute, if I may, just to show you that they're not just present in plasma. We've measured them in placental tissue in humans. This was a study that we performed in 98 pregnant women who were randomly assigned to either fish oil or N3 fatty acids or olive oil from 20 weeks gestation to term. And what we showed in this particular study was that, again, in placental tissue, there's a significant increase in SPM. More importantly, and you can do a lot more, I guess, in rats, because you can actually extract placental tissue during early and late pregnancy. And what this was able to show us was that, okay, you can increase the levels of SPM if you supplement rats during pregnancy with N3 fatty acids. But some SPMs are not increased with supplementation during early pregnancy, but manifest themselves in late pregnancy. And so there are a number of permutations. So I guess what we don't know here is why, when are they switched on, what do they do? There are a lot of questions and I don't have answers. So in conclusion, these relatively new lipids derived from N3 fatty acids play an important role in the resolution of inflammation and maintaining homeostasis. So N3 fatty acid supplementation can increase these SPMs, we've shown that, to levels that have been shown to have biological activity. And maybe they in part explain some of the benefits of omega-3 fatty acids in cardiovascular disease. There are obviously a lot of studies that need to be done, a lot of work that needs to be done. And some of the things that we're currently looking at now is the role of SPMs with alcohol consumption. I mean, low alcohol has been talked about as being anti-inflammatory. Low alcohol, or alcohol also affects the CYP450 enzyme. So that's a particularly interesting one. We're looking in young patients with collaborators at PMH in Perth. We're looking with Fiona Wood in SPM in burn injury. We're looking with an anaesthetist at Royal Perth Hospital, the role of SPMs during light or deep anaesthesia. And we've also got a population study, the RAIN study in Perth, with over 1,000 individuals that will be looking to measure these particular metabolites. And lastly, I want to thank, I won't go through them, all the people and all the funding agencies that have made these studies possible. Thanks very much.
Thanks very much.